Welcome to your Video Download CLE course. This course was created to meet the requirements of state bars throughout the country. Therefore, codes have been embedded in this course. There will be one numerical code in a 1 credit hour course. There may be multiple numerical codes for courses greater than 1 credit hour. To determine if you need these codes, please go to the My Courses page. If your state requires these codes to receive CLE credit, please write down the codes on a piece of paper. Even though you may be watching this course offline, you will need to log back onto the website to obtain your certificate of completion. Further instructions can be found on the My Courses page by clicking any of the blue question marks or the instructions button.
Hi, my name is Dr. Megan Markham, and I am a clinical psychologist at Orange County Psychiatry and Addiction Medicine. Today I'm going to spend a little time reviewing the relationship between neuroscience and addiction, substance abuse, chemical dependency, they're all synonyms. And then I'm also going to explain a little bit about prescription drug abuse, and then a little bit on goals for treatment, or how we look at treating people who come into our office or your office for these kinds of disorders. So in the beginning, I think it's helpful to understand the relationship between substance abuse and the brain, since we're learning a lot more about the brain and how it is affected through alcohol or other substances. And that's really a good foundation for explaining why things are happening the way they are in the brain, why people can't, for example, just stop drinking despite the fact that their family is being affected. Sometimes their job is being affected. Really, every facet of their life is being affected, and yet they are unable to quit using without intervention, without treatment. So we're going to talk a little bit more about that this morning. Okay, I want to explain the difference between substance abuse and substance dependence or chemical dependency. These are just clinical terms, but often they are confused. So substance abuse is the more mild end of the spectrum. That would be a less significant impairment in daily functioning, in physical health, and substance dependence is on the other end of the more severe spectrum. So we define dependence actually as a pattern of self-administration that can result in tolerance. So you need to have more of the alcohol, the drug, whatever it is, to get the same effect. And also you can have withdrawal, and you can have compulsive drug-taking behavior when you meet the criteria for dependency. And so throughout the rest of this session, we're going to focus on chemical dependency or addiction, the more severe end of the spectrum, as the focus. All right, so getting back to the brain. In the brain, there are neurons and there are neurotransmitters. Neurotransmitters are a chemical that is produced by neurons to carry messages from one nerve cell to another. So it's basically the brain's computer signal sending messages back and forth. That involves all kinds of areas of thinking. Neurotransmitters that are associated with addiction include GABA, glutamate, acetylcholine, dopamine, that's a big one, serotonin, and the opioid receptors. The pathways for connectivity become disrupted, so the message is not flowing the way that it should. If you were thinking, for example, about cars traveling down the freeway, when there's no traffic, they're flowing really smoothly, and there's no bottlenecks, so to speak, or kinks in the traffic. And when things are not flowing smoothly, when there's an accident or there's debris in the road, then the messages, or the cars rather in this example, become disrupted from their normal flow. And so that's exactly what's happening with the neurotransmitters. Once there's a different chemical in the brain, so alcohol, heroin, whatever it might be, the messages become disrupted and they're not able to flow freely like the cars down the traffic. So, long-term substance abuse, and then long-term chronic use can be anything from 6 months to decades of use. Long-term substance abuse is associated with underlying disruption in specific regions of the brain. I'm going to go into a little bit of depth about which regions of the brain are affected and explain what those regions of the brain are responsible for. But basically, as an overview, it's important to know that the substance abuse is affecting different areas of the brain and causing problems in thinking. So specifically, areas of the brain that are responsible for motivation and reward and pleasure, impulse control, are significantly affected. And these regions of the brain are found in the amygdala and in the prefrontal cortex. Okay, so a little bit more on dopamine specifically, which is one of those neurotransmitters. Alcohol and drugs increase dopamine in the limbic region, specifically, if you'd like to know, in the nucleus accumbens. These increases of dopamine, these surges of too much of the chemical, they far surpass anything that is naturally occurring in our brain. So the mechanisms are also different in how the neurochemical is released, the neurotransmitter is released. So, for example, natural reinforcers which let dopamine out of our brain are food, like chocolate, certain activities like sex. These create dopamine surges in the brain by directly inhibiting reuptake. So the chemical is not sucked back up, for lack of a better term, by the brain. So it's free-flowing and you're able to feel increases in pleasure. Drugs and alcohol stimulate the neurons in a different way. Instead of inhibiting reuptake, they moderate dopamine firing, so you have this surge of too much dopamine in the brain. So addiction results as a result of flooding. The brain is flooded with dopamine, with norepinephrine, and we have neurobiological changes that result from a constant flooding. So there's constant flooding every time you get drunk, every time you use cocaine, heroin, you're going to have this experience of the flooding of dopamine, and over a period of time, that long-term process of flooding the brain with the dopamine creates changes in the dopamine system, creates changes in the brain in general. So we have some animal studies that we look at as examples of how this happens. So chronic substance abuse in animals led to increased branching of the dendrites and the spine density of the neuron. And I'll explain that a little bit, but specifically in the pathways of the nucleus accumbens and the prefrontal cortex. So I think we're going to put a slide up of what a neurotransmitter looks like. And you can see the branching of the dendrites, which are the little sort of spikes at the end of the cell. And those are the things that become damaged over time. So they get fatter, so to speak. They get damaged in lots of different ways. And those damages, or those neurotransmitters that are affected, are, again, in the areas of the brain that are responsible for motivation and for impulse control. So you're affecting the parts of your brain that would normally allow you to say, that's not a good idea, I'm not going to continue this bad behavior, I'm not going to continue this behavior that, even if it's not bad, is causing me consequence, is costing me money, is perhaps affecting my work, my legal status, with DUIs, with jail, with things like that. Those are the areas of the brain that are affected, and we saw that in animal studies with mice who were given either meth or cocaine, a stimulant, over a period of time. Okay, so another thing that happens as these dendrites expand or become more dense in their structure, it contributes to increased craving for the drug. Okay, so we already just discussed how it affects impulse control in certain areas, but now it's also going to increase the craving that we have for the alcohol, for the drug, for whatever it is that the person's taking. In the pathways for craving, for desire, for really wanting something, they have been enlarged, and therefore stopping use becomes extremely unlikely because your brain has changed in such a way that without intervention, it's very unlikely that you will be able to stop using by yourself. Okay, a little bit more on dopamine. In cocaine abusers, we looked at different brain images, and we saw disrupted dopamine activity in the orbitofrontal cortex, it's a certain area of the brain, and then also in the anterior cingulate gyrus. And these areas of the brain are responsible for impulse control, for inhibition, and for engaging in compulsive behavior. This helps us understand, again, why people continue to use despite the consequences. And it also helps us understand how people get so out of control in their drug use when we look at what's going on in the brain. So that information not only helps us understand how an addiction develops over time, but it also helps us understand what we need to do in terms of treatment and how we need to prepare for the potential for relapse. These changes in the brain take a long time to heal. We have some PET scans that suggest maybe 2 years of complete sobriety before the brain is able to recover from these things. And it takes time for neurons to regenerate, but we do know that neurons do regenerate. Over the last 10 or 15 years of research, we have found that brain cells do regenerate. And so that provides hope for treatment and hope for the person who might think that these are going to be things they have to struggle with throughout their entire life, that the brain has the potential for plasticity and the potential to heal itself over time. So, again, we're going to go back to looking at how relapse can come up, because sometimes we don't have the opportunity to have 2 years of sobriety before stress comes up, before lots of different things that come up that might ignite a relapse. And we also know that the natural reinforcers that I was talking about that emit dopamine, like food and sex, are no longer sufficient for us to feel good after an addiction develops or manifests. And so we don't have as much sensitivity to things like that, and it becomes significantly reduced. So sometimes just the overall seemingly lack of pleasure in life can lead to potential relapse. Okay, let's talk a bit about genetic contributions. There's a lot of discussion about genes and research about how genes, how our genetic vulnerability, how our DNA structure is related to not only addiction but all kinds of disorders. We're starting to learn much more about that. And we have estimates of range between 40 and 60% of genetic vulnerability that can be attributed to addiction. And we have several regions of different chromosomes that have been identified or have been correlated with drug abuse. And now we're looking at new research to explore genes in more detail so that we can locate protective factors against developing an addiction. We have emerging research in genetic markers, so which exact genes are potential markers for carrying propensity toward addiction. And then we're also looking at medications that specifically are designed for different people's DNA that might be helpful to use in the future. Okay, so 40 to 60% of vulnerability toward addiction can be attributed to genetics. And then we also have a significant propensity in the environment to attribute us down the line that may head toward addiction. Stress is probably one of the biggest things that increase the propensity of an addiction, and stress in the environment has been shown to be correlated with relapse and with the initial onset of substance abuse also. So increased stress means increased cortisol levels. Our body and the endocrine system, our hormones emit cortisol, that's the stress hormone, and that is activated when we're stressed. So studies are looking now at how stress responses might be involved through effects on the amygdala and pituitary adrenal axis. There is a particularly interesting study that has been replicated several times, and it's an animal study with monkeys. And monkeys were raised in a lab environment, and some of the monkeys became socially dominant, and some of the other monkeys were subordinate. That just happens in culture and humans as well. Some are more alpha males, more dominant. Other people are more subordinate. So they looked at the brains of these different groups of monkeys, and the subordinate monkeys responded different in a couple of situations. There's a normal situation where the monkeys are sitting in the cage, and they looked at their brain, and they looked at the levels of stress, the levels of anxiety in the amygdala and in the hippocampus, and also in the parts of the brain that are involved with emotional and social processing, and that's the anterior cingulate cortex. Researchers looked at the effects of this stressful situation on how likely monkeys were to engage in taking a drug. So they put a lever with cocaine, in this example, out for the monkeys to choose if they would like to take it, if they would like to continue to take it, and they looked at which monkeys were taking it, which monkeys were not taking it, and they found that the subordinate monkeys were significantly more likely to choose cocaine, and the dominant monkeys were less likely to choose it, and that just compares to their respective typical choices during the days where they stressed them out a little bit. They gave them a little bit of a stress in the environment, looked at subordinate monkeys, dominant monkeys. Subordinate monkeys are taking the drugs because they just have a more propensity to do so in a natural environment. And so that helps us understand what might be going on with humans as well. And once again, that study was replicated several times and got the same result. All right, so stress we talked about, genetic contributions. I also want to spend a little bit of time talking about co-occurring disorders, and then we'll move into more specific research and information on prescription drug abuse, which is becoming an epidemic in the United States. But before we get there, let's talk a little about co-occurring disorders. Those can be defined as individuals who have a diagnosis of alcohol, chemical dependency, anything in the substance abuse range, and then something else that would be the co-occurring disorder. So something else that is in the lineup of mental health symptoms. It could be bipolar disorder, it could be schizophrenia, it could be depression, anxiety, obsessive compulsive disorder, post-traumatic stress disorder. Like I said, anything. Eating disorders are often co-occurring with substance abuse. And any individual who has a mental illness is twice as likely to struggle with addiction and substance abuse compared to the general population. And sometimes I get asked, well, which one came first? Is the substance abuse sort of igniting depression, or the eating disorder, or what have you? And really, which came first doesn't matter. That's not too relevant. It's important to understand the importance of treating both, though. We have to treat the substance abuse, the addiction, and we also need to treat whatever else is co-occurring, the depression, the mood, the anxiety, with the same compassion in order for us to see sustained treatment or see effective treatment. Okay, so how do we do that? There's the standard 30-day treatment facilities that we send people to, those are pretty helpful because a lot of times people really need a change in their environment before they're able to turn things around. So if you think about someone who has an addiction, how much of their time is spent during the day using it, preparing to use it, looking for the next fix or drug or bottle of vodka, and hiding it again, just thinking about it, planning, getting money to pay for it, trying to make sure that everything else is going if you're trying to still work, for example. And so it really takes up about, I would say, 75-80% of the day sometimes. And so in order to have effective treatment, we have to refill that 75% of the day with other things. And so that's why it's really helpful for people to take a break and to go to these residential treatment facilities where they are out of their old environment, where it can be really difficult to figure out how you're going to change 75-80% of your day all by yourself. So that's one thing that we like to do in the beginning stages of treatment. Also, sometimes people need to detox medically if they are, again, sort of dependent or have a tolerance to whatever they've been taking. They sometimes need a medical detox because some of the medications can be extremely dangerous. Benzodiazepines like Xanax and Valium, or alcohol, those are specific types of drugs that can be extremely dangerous if you do not detox safely and medically, if you don't kind of taper down, if you just quit using cold turkey. Those specific medications and alcohol, as I mentioned, can lead to seizure, lead to death, and so it's not safe to detox without medical supervision. That's also a part of treatment. And then pharmacotherapy or medications is also an important part of treatment. And there is a branch of medicine that is addiction medicine that people can get board certified in, or psychiatry, which substance abuse falls under mental health. Emphasis on relapse prevention with whatever medication they're taking, and also choosing medications in the future that do not have the same potential for tolerance and withdrawal. So we want to provide medications that are going to be safe, that people are not going to be able to abuse. And some examples that we like to use are naltrexone, Vivitrol. That's an opioid blocker, so it works for people who have abuse toward alcohol or to opiates, and you take this medication either in a pill or an injection, and it fills all the neurotransmitters with that alcohol and heroin, opiates would normally release, and it fills them for a period of time. And so if you were to be on this medication and drink, for example, the alcohol would not take an effect because the receptors in your brain are already blocked. They're already full. So that's a really helpful medication that we're using to treat alcohol and opiate dependence, and something that can help prevent relapse. If somebody does slip, for example, they won't completely fall down the hill, so to speak, because they'll be able to say, oh, that didn't take an effect, that didn't work, I'm going to catch myself and get back on track. And then we also use other medications like Wellbutrin and Zyban. Those are approved for treating depression and also nicotine dependence, and they can help reduce the craving. And specifically, we're looking at reducing the risk of craving in the use of methamphetamine. And so that's up-and-coming research to add to what we have already for opiates and alcohol. Again, we like to select medications for co-occurring disorders that do not have the potential for abuse, for tolerance, or for withdrawal. So people really need to be encouraged to see a doctor that specializes in addiction medicine or a psychiatrist that specializes in this, because it's a specialized branch of medicine, and your general practitioner or your general ER doctor might not be aware of these things and might not have the best indications for what to prescribe. Okay, special populations. There's a couple of groups of people that we categorize as special populations with regard to drug abuse or addiction. And the first one I want to talk a little about is the chronic pain patient. So chronic pain patients often take a lot of different medications for whatever it is that they are addressing, fibromyalgia or migraines or whatever their issue with chronic pain presents as. And once again, specialists in pain management, specialists in addiction medicine are recommended. There's also new research that we can use in the office on the lines of genetic testing. And it's just a simple saliva test, and the test can show whether people metabolize medication slowly, at a normal rate, or at a rapid rate. So that helps us as providers who are doing treatment to get us data for which medication might work best depending on how they metabolize it, and also what dose is appropriate, because before this it was difficult to really tell. Is someone saying, I have breakthrough pain, I need more medication, because they have breakthrough pain and need more medication, or because they are slipping toward problems related to addiction. So this test is really quite helpful for us to see how they're metabolizing it and gives us some objective data to whatever it is that they're saying to us. Okay, so that's a little bit on medication, and then we also recommend that people who have any issues with alcohol or substance abuse participate in psychotherapy. Once again, just going back to the amount of time, energy, resources spent when people are in the throes of addiction, they really need a lot of support, a lot of continued ongoing support in order for them to maintain sobriety and make progress toward their treatment. So we recommend psychotherapy in addition to medication management for at least the first year of recovery. And there's also a lot of family issues, again, as I was mentioning, work-related issues, legal issues that come up with addiction. And so psychotherapy can be really helpful in looking at addressing some of these issues with whatever's going on in the family. The whole family is always affected by addiction, and so a lot of times therapy is really, really important when somebody decides that they are going to enter treatment, so they can work on all of the issues that are there. And sometimes it's helpful to have more than just an individual therapist. It's important if you're in a committed relationship to maybe consider couples therapy, certainly family therapy, and then education for the family. So a little bit of information on some of the things that I addressed in the very beginning of this session on what's going on in the brain, so that the family members can have a little bit of understanding as to why their loved one is acting in such a erratic manner, in such a way that doesn't seem at all like the person that they know. If they get a little bit of information on what's happening in the brain, sometimes that's really helpful for them to have some compassion or just some basic understanding as to why the things that have happened have occurred. Okay, the last little special population is, well, it's actually just more emerging research. There's other modalities to support treatment, and neurofeedback is another one besides traditional psychotherapy, and cognitive rehabilitation. So neurofeedback is a specific QEEG. It's a little cap that you wear with all these different modules, and it helps retrain the brain. So the wavelengths, the delta, beta, alpha wavelengths get distorted with substance abuse, and this treatment helps realign those. I won't go too much into it, but that's just something to know, that neurofeedback is another resource that we have. And then cognitive rehabilitation is a way to sort of help enhance or help boost the regeneration of the neurons. And they use cognitive rehabilitation for patients who have had stroke, for substance abuse, and patients who are approaching the senior years to kind of make sure the brain stays sharp. And so it's just a bunch of different activities that you use to help regenerate different areas of neurons in the brain, so the ones that are responsible for different cognitive processes or thinking areas. So there's some exercises specifically designed to improve attention and concentration, visuospatial processing, working memory, verbal memory, and then most specific to substance abuse is the prefrontal cortex, that area. So that's, again, the area that's responsible for impulse control and motivation and long-term planning, complex thinking. That's the area that is significantly damaged by substance abuse. So doing exercises to boost this area is really going to be quite helpful in terms of getting to that mark faster than perhaps the 2-year standard period. Okay, so sometimes I like to explain that cognitive rehabilitation is kind of like a workout for your mind. So if you go to the gym and you work out your biceps and your quads and you do cardio for your heart, you get a comprehensive workout for your physical health. And the cognitive rehabilitation is the same idea. It's different exercises, different activities to strengthen different parts of your brain and your thinking. So it's kind of a mental workout. And that's, again, really quite helpful, especially for substance abuse.
The course code is 091. The course code is 091.
All right, this next segment, we're going to talk a little about prescription drug abuse and addiction. I'm going to define prescription drug abuse and go through the risks of commonly abused prescription drugs, give you some examples so you know what will likely come up when you see it. So in defining prescription drug abuse, we can look at it as the intentional use of a medication without a prescription, or the intentional use of a medication in a way other than as prescribed, or taking it just for the feeling that it causes. We're going to look now toward an overview of the most commonly abused prescription drugs and see how these may limit an individual's ability to function over time. So there's about 3 classes of commonly abused medications. The first one that we're going to go through is opioids or opiates. These are commonly used to treat pain. Examples of opioids or pain medications are Percocet, Vicodin, OxyContin, codeine, and morphine. It's the same category as heroin, and so for that reason they are highly addictive. They act in the same way on the same receptors as heroin, and people who abuse them sometimes alter the route of administration. So instead of swallowing their medication, they will change to snorting or injecting it to intensify the effect, and some will even switch to abusing heroin because it's so much cheaper than the prescription pain pills, and when you can't afford it, sometimes you will just do things that you didn't think you would do before, and so people have been highly likely to switch from prescription opioids to heroin over time. There are estimates of about 2 million people in the United States who meet the abuse or dependence criteria just for prescription opioids or pain pills. The potential for overdose with these medications is really high, either alone, just taking it by itself, or with alcohol, or with other medications. Can depress respiration. It can sort of slow your lungs down, slow your heart rate down, and that can lead to death. So we have unintentional overdose with this category of medication quite often. In fact, it has quadrupled since 1999, and it now outnumbers the prescription pain pill overdoses outnumber those overdoses from heroin and cocaine combined. There's also a increased risk for acquiring HIV or other infectious diseases because of the risk that comes with sharing needles, that comes with unsterile equipment, and also just people who don't even inject the drug can also increase their risk through judgment problems and risky decision making that goes along with abusing drugs like these. And these are medications, prescriptions, and so that's interesting to think that you have an increased risk of HIV when you're abusing your pain pill, but you do. One kiddo in particular, 15 years old, he had taken marijuana, I think Xanax, and a quarter of a pill of Opana, which is a prescription opioid used to treat pain, and he passed away. And that's really not a very high dose. So the potential for overdose, again, is just really, really high in this class of medications, and so it's something that is a giant mental health problem. Especially if you use these types of medications with alcohol or other drugs, it has the potential to depress respiration, so slow down your lungs, and that can lead to death if you just stop breathing. Unintentional overdose deaths involving prescription opioids have quadrupled since 1999, and now the prescription pills, the overdose from these outnumber the overdose from heroin and cocaine combined. So it's a really big problem, as I mentioned. Also, there's a heightened risk for HIV that comes along with using these medications. Injecting medications like these will increase the risk of HIV and other infectious diseases through the use of unsterile or shared equipment, and non-injection drug use can also increase these risks, making sort of having drug-altered judgments and poor decision-making and risky behaviors, which can also increase the risk of HIV and other infectious diseases. So a lot of things to consider when thinking about the problems that come along with that. That's the first class of medications. The second class is the CNS depressants, or central nervous system depressants. These are mostly used to treat anxiety and sleep disorders. Examples of these include Xanax, Valium, Ativan, Klonopin, and Ambien. So these drugs are also highly addictive, and in chronic users or abusers, discontinuing them without a physician's guidance can bring about severe withdrawal symptoms, including seizures that can be life-threatening. And the potential for overdose in this category is also very high. High doses can again cause severe respiratory depression, and this increases when these medications are combined with alcohol or other medications, especially opiates. All right, one more category to go through. Stimulants. Stimulants are sort of the opposite end of the spectrum from the other two classes of medication. They are often used to treat ADHD and narcolepsy. Problems and health-related consequences that come with stimulants are psychosis in long-term use, so losing touch with reality, having hallucinations, having delusional thoughts, seizures also can come up, cardiovascular complications. Examples of these are Adderall, Ritalin, Vyvanse, and there's increasing concern with this specific class of medications. The Drug Abuse Warning Network, they are responsible for monitoring ER visits in selected areas across the nation, and they have reported that approximately 1 million ER visits in 2009 could be attributed to prescription drug abuse. Of those 1 million, about 343,000 involved opioid pain relievers, and that is a rate that has more than doubled in the last 5 years. ER visits also more than doubled for the central nervous system depressants, that category. They were involved in nearly 22,000 ER visits in 2009. And this is in New York City, by the way, these numbers. And as well as central nervous system depressants were involved in 363,000 visits. Benzodiazepines, so the Xanaxes, the Valiums, comprise the vast majority, and rates for a popular prescription non-benzodiazepine sleep aid called Zolpidem or Ambien rose from roughly 13,000 visits in 2004 to 29,000 visits in 2009. So more than half of ER visits for prescription drug abuse also involved combination of drugs. So there was more than just one medication involved in what was going on. Okay, so if you take these over time, you prescribe them, right? So you end up taking them over a period of time. You can become very tolerant to the medication. So we can look at this as an example of someone that you might know who has been drinking for a long time. They can drink all day long and not really look like they're falling down drunk. And somebody who never drinks can have, half a margarita and look like they're falling down drunk. So that's sort of an example of what tolerance looks like. And when individuals use medications that have a potential for abuse, sometimes tolerance is a factor. So, for example, a half a pill of Xanax will help you fall asleep the first month that you're taking it. And then the second month you're taking it, you have to increase it to a whole pill because the half a pill isn't working anymore. And this is how we can lead up to an addiction, or we can start to acquire a dependence. Tolerance, again, it's defined as getting less and less of a response to the initial dose or to the prescribed dose, or having to take more than previously to get the same desired effect. Dependence is specifically defined as the body's set of physiological responses to a repeated drug intake. It can lead to withdrawal symptoms if the drug is quickly discontinued. Intolerance and dependence can develop in a really short period of time, within a period of days in some cases, often before the individual is even aware of the changes that have occurred within the body. This is often what makes stopping or abstinence so complicated and so difficult. Withdrawal from opiates is really, really painful, which makes detox difficult. Often people will continue to use opiates just to avoid the withdrawal symptoms, just so that they don't get sick, because the symptoms are terrible, painful, flu-like, just awful. Okay, so looking at prescription drug abuse and how big of a problem it is in the United States, we have research from 2010, and in 2010, approximately 7 million people were prescribed psychotherapeutic drugs. Oh, no, sorry, were not prescribed psychotherapeutic drugs. So they were taking non-medical use of the whatever, the Valium, the Vyvanse, the whatever. So in 2010, 7 million people were taking prescription drugs non-medically, and that is about 3% of the U.S. population. This class of drugs is broadly described as those targeting the central nervous system, including drugs used to treat psychiatric disorders. The most prescribed commonly are pain relievers. There's 5.1 million prescriptions for pain relievers in 2010. For tranquilizers, there were more than 2 million prescriptions. For stimulants, over 1 million prescriptions. And for sedatives, sleep aids, about 500,000. Why are we taking so much medication? What is driving this high prevalence? So there's a few different factors that are related here. For one, people often think that medication is safe, or they think, it's not a street drug, so I'm going to be okay. It's in my mom's medicine cabinet, so I'm going to be okay. My mom takes it, my grandma takes it, I'm going to be okay. And there's this misconception about safety that comes up a lot. So also people think, well, my doctor prescribed it, and it's got to be safe to take in any circumstance. If 1 is good, 3 is better, you know? That's not the case, obviously, not the case at all. And prescription drugs act either directly or indirectly on the exact same brain systems that are affected by illicit drugs. So the same kind of neurological changes are happening when you take prescription drugs that are happening when you take illegal drugs like heroin, cocaine, methamphetamine. It's all very similar in terms of what's going on in the brain, and so that makes it extremely dangerous. Using somebody's medication other than prescribed, even your own other than prescribed, can potentially lead to a variety of health problems, adverse health effects, not to mention developing an addiction, acquiring an addiction, an overdose. I can't tell you how many people I have seen come to treatment with a prescription drug abuse problem that they did not intend to acquire. Obviously, nobody really intends to become an addict, but these people really don't know how they got there. Their doctor, once again, not a specialist in addiction medicine, had prescribed some kind of medication. So maybe they prescribed them Valium, or they prescribed them a Soma or something for pain, and the person has stress in their life, they have problems in their relationship, so they take a pill, feel better, they start to misuse it a little bit, and then in a very short period of time they don't know how they got to where they got in terms of the symptoms and the adversity of how they got to where they got using or misusing their medication. Increasing environmental availability. So what does that mean? That just means that there are basically more prescriptions out there, more pharmacies, more ways to acquire the medication, either legally or illegally. Some illegal ways are just to take your friend's medication, for example. I don't think people realize that's a federal offense, and it's a huge deal, but people do it all the time. And that is a way that people are getting access to these medications. So between 1991 and 2010, the amount of prescriptions that were written for stimulants increased from 5 million to 45 million. So that's in the span of, what is that, from 1991 to 2010, not that long. 5 million to 45 million. And then for opioids, or for the pain relievers, in 1991 there were about 75 million prescriptions, and in 2010 209 million prescriptions. There are varied motivations for why people abuse these medications. The most probably easily recognizable example is to get high. But sometimes people are using them to counteract their anxiety, to try and reduce or alleviate pain, to help them with sleep problems, or to enhance their cognition. Whatever the motivation is, prescription drug abuse, prescription drug misuse comes with really, really serious risks. And so it's something to be very aware of. Okay, so the number of deaths has increased. In 1999, the number of deaths from pain medications, from cocaine, and from heroin were all about at the same level, all about 300,000 deaths. And this was an unintentional drug overdose by those types. There were 3,000 for 100,000 people, and so they were all about in the same range again. In 2008, the last time they took a sample, the heroin is at the very bottom of the overdose category at still about 3,000 per 100,000. And The cocaine is also just slightly higher at about 4,000, but the prescription pain pills jumped from about 3,000 up to 13,000. And so that's the only category that specifically spiked so high. And there is a chart that you can see the data for what represents what I just said that we'll put up. Okay. So warning signs, steps toward treatment, what do we want to sort of pay attention to and look at in our families, in ourselves, in our loved ones? We really want to be mindful about the adolescent population. They are a specific high-risk category, and for many different reasons. First of all, they don't have the experience and the education to understand the potential dangers, so medication looks like it's safe, right, to an adolescent. It looks like, oh, it's a Tylenol or whatever. They don't have the capacity to really understand how dangerous they could be. And also, adolescents' brains are still developing, and our brains continue to develop until about age 25. And so in the adolescent brain, the areas that are still developing are responsible for impulse control. As you know, the adolescents of the world are not really very good at filters or managing their impulses. That develops later. And so because that area of the brain is still developing, they're not able to make the best decisions. So they'll say, oh yeah, it sounds like a good idea, or they don't think through the potential consequences of what might happen from taking prescription pills or drugs of any kind. And so they're at an increased risk to just engage in this behavior anyways. And then if you remember back to which areas of the brain I was saying are affected by drug abuse, it's the same areas of the brain in the adolescent that have not yet been developed. So not only is the brain unable to develop, it's actually damaging the areas that are not developed anyway. So it's sort of have it like a double-edged sword. It's attacking the area that is the weakest. So that makes, like I said, dependence or abuse with adolescents a specifically increased risk for them, and so we want to make sure we talk in great detail about prevention with that population. So that's just a warning sign again. Another warning sign for really any age or group is having this desire to stop whatever it is, drinking, using medication, whatever it is, like I said, but not being able to do so despite consequences. So despite a DUI, despite a problem at work or whatever consequence might come up, you're not able to stop. That's a warning sign that treatment is probably looking like a good idea. Also, just a sort of a warning sign or a common indicator in people who are abusing pain medications are contracted pupils, so really tight, small pupils, and also facial scratching, facial itching. It's another just a little sign. And then pretty much just any impairment in your activities of daily living. So you're not able to sort of manage your relationships. You're not able to get to work some days. You are not able to take care of yourself. Your financial responsibilities, you have more legal problems than you know what to do with. If any of these come up, these are what we call impairment in activities of daily living, so you're not able to function like you normally would, and that's a huge warning sign. If any of those areas, if more than one of those areas become affected or impaired, then that's another sign or suggestion that you should probably consider treatment, or your loved one should probably consider treatment. And so what are the steps if we need to sort of work toward treatment? Well, the first step is to make sure that you seek medical attention, because again, some of these classes of substance abuse require a medical detox, and so that would be really the first stage if you are dependent in a way that requires medical detox, that you get that treatment first. And then after you have detoxed, it's important to have some education around what is going on. with the brain, with how to sort of prepare for sobriety. And sometimes people will think, well, I had a problem with pain pills, but I don't have a problem with alcohol, so I'm just going to drink and not use the pain pills. And that can be really quite risky because the areas of the brain are all affected the same way. It doesn't matter what type of drug it is, what class, if it's a prescription, if it's an illicit one, if it's marijuana, it doesn't matter what it is. They're affected in the same areas of the brain. And so because you have a problem with one, makes you an increased candidate for a problem with another class. And so we really like to see complete sobriety as the recommendation for treatment, for recovery. And then social and professional support. Okay, so professional support for whatever's going on at work, for whatever is going on with legal concerns, any legal problems that have come up, and social support. Social support is again looking at all of your mental health and making sure that you have a therapist, that you have people in your environment who are supporting your goals, so you're not spending time with the same people who participated in misusing prescription pills or drinking in excess with you in the past. That's what we mean by social support. So a lot of times people will start going to meetings like 12-step support group meetings like AA, or Smart Recovery is a non-12-step based but another recovery-based support group that people will tend to go to in the early stages of recovery, and then sometimes even later, sometimes 5, 10, 15 years later, people are still attending these social support groups as a way to continue their recovery and to enhance their ability to thrive after substance abuse. Okay, so I think I'll just go through an example of what I have seen. We have just a little bit more time, so I'll go through some examples of what I've seen and how it might relate to legal practice. I think probably the biggest thing I see here is in the hospital setting rather, is in the ER. So in the emergency room, we see a lot of overdose or potential overdose. And what it looks like is problems in the family that lead to this. So in the youngsters, it's I ran away from home and I, got high for 3 days and my mom's here now, and so what do we do? And in the older people, it's I wasn't trying to kill myself, I swear. I just was having an argument with my husband, and I drank and I took some sleeping pills. I just wanted to just numb out, go to sleep, just not feel. And I hear that so many times, and it's just really, really dangerous. So that's probably something important to know, that if you're working with people who have legal problems, that it's important to make sure that you just check for substance abuse, and that if it's a problem that they're participating in treatment, they're not going to the ER, but having consistent treatment after the ER. That's one thing that I think is probably pretty important. And then I guess outside of the hospital setting, I would say there are quite a bit of people who fall into the category of substance abuse, substance dependence as a direct result of a work-related injury. So these people are going to their workman's comp doctor and getting a prescription for some sort of pain reliever because they've had an injury on the job, and they become addicted over time because of a lot of different factors that are correlated. So first of all, there's just the physical pain that is involved in the injury and what the medication is intended to treat. And then when people are off work for a while, they tend to have increased stress about their finances. Sometimes generalizing just a little bit here, but sometimes I see men who have work-related injuries who start to feel depressed because they are unable to work. again, anxious about finances. So they have all this stuff going on, and it just tends to exacerbate the prescription drug use, which in time turns into misuse and turns into addiction. So that's also something just to be really mindful of. I can't tell you how many people I've seen with work-related injuries who acquire a problem with pain pills. So that's probably good to know in your practice. And then just one more time, just highlight the importance of monitoring the adolescents and the little ones, and making sure that the medicine cabinets are really secure and that you spend time talking with them about the danger of prescriptions, so that they, will have the skills and have the education to say no if something comes up at a party, or if something comes up where it seems like it might be a good idea to just try something, that they know the dangers. And so, that being said, that was just kind of an overview on what's going on in the world of neuroscience. And again, my name is Dr. Megan Markham. Thank you very much. Okay, so we have a question about substance abuse within the profession of attorneys and why there is an increased risk for that population specifically. My guess, without doing research on this, would be a lot to do with stress in that profession. There's a high level of stress that goes along with being in court, and managing a lot of different cases and everything that relates to being an attorney. And so, as I mentioned before, increased stress is a risk factor for substance abuse. So that in and of itself is something to be concerned about. And also there's a stigma associated with mental health and with substance abuse in general that touches everybody, but I imagine touches attorneys in a different way. And so people will a lot of times self-medicate. They will drink too much. They'll abuse their medications without really thinking that they have a problem, without really identifying it, looking at it. And that can be problematic because, again, the tolerance, the propensity toward overdose can come up so quickly and in such a short period of time that it's really important to look at it and to ask for help. And there's absolutely nothing to be ashamed about in terms of looking for mental health treatment, for substance abuse treatment. If you, again, have a medication or a problem with alcohol, something that you want to stop but you can't stop, or you're using it to sort of help reduce your stress or alleviate anxiety or go to sleep every single night, it's really something that you can talk to your doctor about. With all the HIPAA compliance laws, it's very safe and private for you to do that without feeling like there's a stigma associated with it. And in addition, just remembering all of the things that were discussed in the beginning of the session about what happens in the brain, to know that it's not a function of bad behavior or a choice, sort of a volitional thing, that I just want to encourage everybody who has a loved one or a coworker or even yourself concerned about substance abuse, prescription drug abuse, that you look at it and get it treated so that you don't end up in one of the statistics that I just mentioned.